too intrusive. I apologize. Okay. So, moms with hepatitis C. So here's some data from several years ago, but really hasn't changed since then, showing the prevalence per live births. And you really probably didn't need me to draw that square around Central Appalachia, but there we are, right? We have the highest prevalence of women giving birth to children. And here's data from a retrospective study that was very, very large, right? Almost a little over 39 million live births, of whom 0.4% of these births were among women who had hepatitis C. And you can see on the left the dramatic increase in the hepatitis C per live births. And then on the right-hand side, you can see that this increase is really quite dramatic among indigenous populations and white women. And from the same study, on the left, you can see that the rate is, again, pretty stable among women who have graduated from college, but again, rising pretty dramatically among women who haven't. And sadly for us here in West Virginia, you can see on the right-hand side that both remote rural and rural adjacent areas track together and again show this incredible increase. So this is what we're dealing with. And of course, it's all bound up with our drug epidemic. So here are the current recommendations from both the CDC and the American Association for the Study of Liver Disease and the Infectious Disease Society of America. We are supposed to screen everybody, risk independent, at least once in a lifetime, except in settings where the prevalence is very low. I shouldn't have even said that because that's certainly not West Virginia. But among women who are pregnant, they need to be screened during each pregnancy. And this should be a routine part of prenatal care everywhere. But again, this, a compelling issue for us in West Virginia. So here is data from the 7-year period from 2012 to 2018, looking at adverse pregnancy outcomes. And you can see that there's almost 134,000 who had hepatitis C, and they were compared to this very large number, almost 29 million, who did not have hepatitis B or C. And for hepatitis C, the vast majority, right, 82% were white, 80% were Medicaid recipients, 14% delivered in a rural hospital. And all of these problems, maternal mortality, length of stay, preterm labor, there was evidence of a highly statistically significant increase among women with hepatitis C compared to the uninfected women. So now if we think about the risk of vertical transmission, mother-to-child transmission, overall, and this is based on a meta-analysis that looked at 17 different estimates, overall it's around 6%. And the higher the maternal viral load, the higher the risk of vertical transmission. If the mom has both hepatitis C and HIV, then the risk close to doubles, goes from just shy of 6% to almost 11%. And additional risk factors include prolonged rupture of membranes, any kind of obstetric procedures that expose the infant to maternal blood, like internal fetal monitoring or lacerations, and then, of course, maternal injection drug use. What's not associated with the increased risk of vertical transmission is whether the baby is born by standard vaginal delivery or by cesarean section. And breastfeeding is not a risk unless there is somehow, enough damage to the nipples that there's blood. So generally, we think that vertical transmission of Hep C happens mostly at or shortly before delivery, but recent data in a small number of mother-infant pairs suggests that it may actually occur earlier in gestation, somewhere in the last trimester between 25 and 36 weeks. And so that really means that if you could intervene to prevent this, you would need to do this considerably prior to delivery. So here are the current recommendations, again, from the Joint Hepatology ID guidelines. Of course, it's always best to prevent things well in advance, but this is not necessarily a population that for whom a lot of advanced planning is the byword. You would ideally like to cure hepatitis C among women of childbearing potential before they get pregnant. And if they're determined to have hepatitis C as part of the prenatal care, then these individuals need to understand the potential risk to the infant. Though it's not that huge. As I said, it's about 6% if they don't have HIV. But they are going to need the follow-up and testing for both themselves and their infant. And a small proportion of women actually spontaneously clear Hep C after they give birth. And so it's important to reevaluate and see if that has happened to a given woman. Now, otherwise, prenatal and intrapartum care is the same for these women as it would be for anybody. It is important to sort of evaluate the woman's hepatitis C by looking at the routine liver labs and the hepatitis C viral load. There is already the jaundice of pregnancy, which is due to, as the slide says, intrahepatic cholestasis. So you really need to think about this, especially in pregnant women who have hepatitis C. And of course, if they have advanced fibrosis or cirrhosis, then there is a real risk for both adverse, both maternal and infant outcomes. Now, breastfeeding, unlike women who have HIV, breastfeeding isn't contraindicated, except, as I said before, if there's the possibility of contact with maternal blood from damage to the nipples. And there is this issue, and I'll come back to it in a couple of slides, about treating women during pregnancy. But I want to stop for a second and remind you all that there is the West Virginia birth score. And and there's the URL for it. And the birth score was amended several years ago to track maternal hepatitis C. So I have, it's kind of tiny print reproducing the form on a slide, but I have circled in red where it says infant diagnosed with neonatal abstinence syndrome and maternal hepatitis C. So we are trying to track this because we can offer children who have reached 3 years of age curative therapy for hepatitis C. So if an infant is unfortunate enough to have contracted hepatitis C vertically, then these infants need to be in care and followed so that at the earliest opportunity they can be cured. So here's what I said I would come back to, and this is the issue about, should we treat women with hepatitis C who are pregnant? Should we treat them during the pregnancy? And I'll go through some of the arguments pro and con. So because so many of these women have their hepatitis C through injection drug use, there's a large proportion of them who are lost to follow-up after they deliver. And so one argument in favor of treating late in pregnancy would be to reduce this postpartum loss to follow-up. Of course, if you can cure the hepatitis C before the possibility of transmission, then you can decrease the rate at which mother-to-child transmission occurs. Children who do acquire hepatitis C vertically wind up developing fibrosis and even cirrhosis at an earlier age than children who acquire hepatitis C through other avenues. And this is another reason why it's really important to get these children into follow-up and identify them as individuals who are going to need close follow-up, because the last thing you want is for, a child who was infected through vertical transmission to be 25 years old and have cirrhosis. And the last argument in favor is that the surveys have shown that, most of the women with Hep C are interested in treatment if it would decrease the risk of their giving their infant hepatitis C. The arguments against, of course, is there's limited data, although there are some, and there's more all the time. There is, you can treat women who are breastfeeding, and it's, and this is not yet FDA approved, but because there have been published studies, there are clinicians who are offering treatment to women starting in the 3rd trimester. And the guidelines say now, a change is that, quote unquote, treatment can be considered during pregnancy on an individual basis after a patient-physician discussion about potential risks and benefits. So I think we are moving more and more all the time toward earlier treatment. Of interest, the classes of drugs that we use to cure hepatitis C are the same families of drugs we use to treat HIV. And there are women who take these drugs throughout pregnancy. So if you started treatment in the 3rd trimester, you would be well beyond exposing the infant during the period of organ formation, which is only in the 1st trimester. So there is a study that started a couple of years ago that's looking at 100 mother-infant pairs, and the acronym is STORK. And this is a prospective evaluation of treatment that starts in the 26th week, so in the 3rd trimester. Now, the closest one to us is at University of Pittsburgh. And we will get more data from this study, although enrollment is slower, I think, than they had hoped. So because of the primary risk for hepatitis C in these women is injection drug use, there's a lot of pieces of the harm reduction continuum that are valuable to think about in terms of managing these women. Offering treatment for opioid use disorder or other substance use disorder, making sure that they have access to hepatitis C care after they deliver. Thank you, I'll be there. Sorry, Max was being groomed today. They really should receive very targeted education and counseling about their hepatitis C. And if they are still actively injecting, of course, they should be referred to a syringe services program. Sadly, we only have 8 or 9 in the state now, thanks to the change in the laws governing syringe services that was passed a few years ago. So this is the whole panoply of, from preconception to postpartum, of all the ways that we could help these women sort of cope with the underlying risk for hepatitis C, which is their drug use, and get them into care, get them cured, and prevent reinfection. So there are, where is this? Here we go. There are now new recommendations for screening infants and children, and these take the place of the previous guidance. The previous guidance was you wait till the child is at least 18 months old, which is the point at which maternal antibodies should be gone, because if you test them younger than 18 months old, you may well just be picking up maternal Hep C antibody. What we should do now, the guidelines say, is to test all perinatally exposed infants with Hep C RNA, not an antibody, just go straight to the viral load at between 2 and 6 months of age. And then if this is negative, then there's really no further follow-up that's required for these infants that were potentially exposed. For infants that were born before this change in the recommendations, who are not yet 18 months old, then they should also have a Hep C RNA done. And for children who are now 18 months or older, they need the standard antibody with reflex to RNA PCR. And hopefully with this new approach, we will really identify perinatally infected children early and get them into care, because as I said, they can be offered curative treatment starting at age 3. So let me stop there, and I am happy to take your questions. And I hope that noise wasn't too terrible in the background. There's really nothing I can do about it.
Fortunately, I couldn't hear anything, so.
Oh, good, because it's really very loud to me. Robin, do you want to ask a question? Go ahead.
This actually worked out great because I just got a referral yesterday from an OBGYN office on a pregnant patient, and I was really thinking that I wasn't going to be able to treat her until after delivery. So now I'm probably going to get her in for an appointment, and then I'll just kind of work her up, and then maybe I can present her at an echo, an upcoming echo case, and then maybe I can treat this pregnant woman. So, is there anything that I need to be aware of when I'm bringing her in for her first visits?
Well, there is published data. The first author is Catherine Chappell, Chappell, that did a pilot study at the University of Pittsburgh a few years ago, where women who had hepatitis C, there were, I think, 11 women who wound up being treated. So it's not a huge number. All got treated with Epclusa starting in the 3rd trimester, and they all did fine. It's a small number and you expect a 6% transmission rate. So none of the infants had Hep C, but the women tolerated it, the drug, without a problem. And there didn't seem to be any negative effects on the infants. And as I said, we're sort of accumulating more data as we go. I know in some places, I know of several practitioners in New York City who routinely offer this to their patients. I think if you explain to this new patient of yours that this is not at this point FDA approved, but there are data that show that it does not appear to be harmful to the pregnancy or to the infant, and it might reduce the risk of transmission, then I think at this point, it's just clearly a clinician-patient discussion, and whether you just have to document that this was discussed in detail and this is what the woman either agreed to or didn't agree to. If she decides not to do this during pregnancy, then, keep her engaged in care, offer her therapy right after she delivers, and, and then offer to, or whoever's going to care for the infant, make sure that they do an RNA PCR once the infant is at least 2 months old. So I think at this point, it's really, you know, it's really it's really a personal decision thing.
Okay.
I don't see a reason not to, but it's not my baby.
Okay. So if she elects for treatment, and in this, this is just a what if scenario. If she were still in the middle of treatment before she delivers, I wonder if Eclusa is considered safe for breastfeeding. I think you mentioned something before about Hep C, they can breastfeed, but I
Yeah.
wonder if it'd be okay with Eclusa too, I'm assuming.
Well, you know, it's the same thing. These drugs will be excreted in breast milk, so the infant will be exposed just as the infant was exposed in utero. I don't think that it'll be any more, I can't imagine that it would be any more harmful to the infant than the in utero exposure.
Okay.
You don't know at what point she is in the pregnancy, do you? Not yet.
I've got to get her in for an appointment, so I'm not
Okay.
sure.
You know, hopefully this was done early,
Mhm.
and you know, she's got, you and she have plenty of time to decide before week 26 whether she wants to do it. And you know, women are at risk of earlier onset of labor when they have chronic Hep C. So, you know, I think you'd want to do it promptly. I think you'd want to start promptly so that you
Okay.
know, she gets the benefit.
All right, thank you.
You're welcome. And that would be a great case to present.
Yeah,
Once you have more of the details. Go for it.
thanks.
Sure. Any other questions?
I was going to add something. Robin, I don't know if your patient has Medicaid. If they do, or if you have any in the future that have Medicaid, pregnancy is part of one of the reasons we wouldn't be able to prove it at our level. But if you want, just submit with your request an appeal letter with that info. And if you want to also, feel free to shoot me an email or anything. I can reach out to BMS to kind of further discuss with them and give them some of this background info for when they review that appeal. I'm happy to do that.
Right. So Angie, that I'll send you that. I'll look for that article, but that's Catherine Chappell, Chappell. And I believe there's now a vertical transmission study underway using Maveret and not Epclusa, but the published work is with Epclusa.
Good deal. Awesome. Yeah, send that my way.